My name is Sean Thomas, and I'm the author of Be More Today, a 40-day guide to a better version of you. As doctor of physical therapy, I've seen thousands of people do great things. They came to me with ailments, physical ailments, pain, issues, and they got through them, all because they decided in their mind they were going to do it. And I guarantee you, if you just trust the process and be persistent, you too can be the best version of you. Have you ever been out and about, traveling, running, and you're trying to figure out how to hold everything on you? Phone, keys, wallet, lip gloss, lip balm, your gels. I gotta tell you, the best belt you can ever use is by one company, and that company's name is Spy Belt. Spy Belt makes an innovative running belt that solves the pocket list problem. Whatever small personal items, SPI, need to be toted during physical activity, you will hold it in your very discreet, expandable running belt with comfort and ease over any distance. And those are the words taken right from Kim Overton, CEO and founder and inventor of the Spy Belt product. Kim's a great friend of mine. She sponsors the Be More Today show, and we support all things that Kim does. So, if you're looking for the best belt on the market, visit spybelt.com today and check out all their amazing belts. I wear them for all my runs, and I think they are the best. If you go on today and use the code BeMoreToday, you can get 10% off any of their merchandise. So, check out spybelt.com, and let's continue to be more today with Spy Belt. Run smart, run free, run with Spy Belt. Don't let aches and pains hold you back from living your life. At JAG Physical Therapy, our experienced clinicians create a personalized treatment plan that fits each and every patient's needs uniquely. Whether it's recovering from an injury or enhancing your performance, we've got you covered. With over 150 locations throughout New York, New Jersey, and Pennsylvania, there is sure to be a JAG Physical Therapy location near you. Visit jagpt.com and book an appointment today to get back the life you love. That's jagpt.com. jagpt.com.
Welcome to the Be More Today show. Don't forget to like and subscribe to our show today. Now, let's hear it from our host, Dr. Sean Thomas.
What's going on, folks? Your boy here, Dr. Sean Thomas, back in the building with the Be More Today show. We are back in the building, folks. And we are now here in the month of May. The month of May. We are moving and grooving into this month of May, and it's just a blessing to be here still as your host for the Be More Today show, now here in season number 6, as we all strive to be more alive and thrive in 2025. I salute you for being a part of the Be More Today family. As you already know, Be More Today is a movement. We've been doing so many great things this year, from more merch still being on our site, BeMoreToday.com. My first book still being out there, Be More Today, a 40 Guide to a Better Version of You. My second book, Project More, which we just had our first reading for that book as a group this past April into May, was amazing. Just connecting with people across the country as we read through Project More together, doing workouts together in conjunction with our Steps to Greatness Challenge. 172 people across the country putting in their steps, and we had 8 teams this season. We had 172 people out there getting their steps in, and it was incredible. First of all, seeing community come together for fitness. And for whatever reason, when you incorporate competition into anything, people get revved up. And I was happy to see people competing against each other for themselves, right? Competing against each other to be healthier for themselves, be healthy for their community, be healthy for their families, for their coworkers. It was a blessing to really see that. And I salute everyone who signed up for the challenge. We're going to have the challenge again in July 1st. Will be our next challenge. The sign up for that starts on June 1st. If you want to be in the summer season for the Steps to Greatness Challenge, visit BeMoreToday.com and you can sign up starting June 1st for our July 1st challenge. Again, 40 days, 10,000 steps every single day for 40 days. And any more questions for that, info at BeMoreToday.com. Send me an email. I will give you more information about that as you want. The show now is heard in 91 countries, over 73,000 downloads. Again, thanks for your love and support. This show continues to grow. And I encourage you to follow us on Facebook and Instagram at BeMoreToday.show, at BeMoreToday.pt, and your boy here, Dr. Sean Thomas. We are also on Spotify and our podcast, and of course on YouTube. So subscribe. Thanks to our sponsors, Spy Belt. As always, spybelt.com for the best running belts in the world. Our sponsor, Jag Physical Therapy, for always trying to get us back to the life that we love. And our monthly patrons for always giving to this show every single month. I appreciate it. It never goes unnoticed. Our quote for today is simple as always. My message is keep moving. If you do, you'll keep arthritis at bay, by Donna Mills. One thing that everyone that I see at my job, patient wise, says is that they don't want anyone to get old. Don't get old. And one of the reasons people say that is because King Arthur rules in their life sometimes. Arthritis is that thing. It's unbearable. It's painful. It's stiffness. It's all these different things. And whether you're someone who had surgery or someone who had just wear and tear on the body or someone who's just getting more seasoned in their age, arthritis is something that creeps in and becomes debilitating in some degrees. It is known as being a disability in many, many categories. And there are definitely different ways that people try to manage it, deal with it, get through it. But I wanted to just focus on today on just talking about arthritis and ways that you can really make conscientious efforts to make a change in your life, right? The thing you can do to deal with, manage, and live with arthritis, whether it means having surgery or just staying more active. And I thought, who can I bring on the show to talk to us about arthritis and ways to keep moving with and without surgery with arthritis? And my guest on today's show is my new friend, Dr. Armin Arshi. So please listen to our show as we talk about arthritis and the decision to replace or not replace. That is truly the question. Dr. Armin Arshi. So, ladies and gentlemen, boys and girls, pets included, please welcome to the stage our guest on the Humor Today show, Dr. Armin Arshi.
All right. So my name's Armin Arshi. I'm a hip and knee replacement surgeon, orthopedic surgeon at NYU Langone in New York City. I originally am from Southern California, where I did my training in college, medical school, and residency at UCLA Medical Center in Los Angeles. I thereafter completed a fellowship in hip and knee reconstructive surgery at the Rothman Institute in Philadelphia. Thereafter, I joined the faculty here at NYU in 2022, where I specialize in all facets of hip and knee arthritis care. I perform primarily joint replacements, partial and total replacements of the hip and knee, and provide the full spectrum of care, both people who need surgery and who don't. In addition to my busy practice, I'm involved pretty actively in research in terms of both clinical and translational research, looking at implant design, patient outcomes, and a particular interest of mine is return to sport after joint replacements. And I also am involved with training future surgeons, both residents and fellows with the NYU Langone Orthopedic Department.
Amazing, Dr. Armin Arshi. I appreciate you for sharing that with us. And lots of questions on the podcast today. So let's just get right into it. You are a knee and hip specialist, and many of our listeners are functional people. They're either patients that we've had in the past who are now getting back to living their lives, or they're runners who are trying to go out there. They may have some arthritis in their bodies, but they want to keep pushing. And as you know, King Arthur is always on the minds of many people when aches and pains start to come in. So my first question to you is, how do you function? Or what are your tips for how people can function when arthritis is something that they may have or may have in the future in their lives?
Yeah, so I think the important thing to keep in mind is King Arthur catches us all and age catches us all. There is it's inevitable that the body ages and things that cannot be regenerated, such as cartilage in your joints, will eventually wear out with time, and that can lead to a painful, achy joint. For patients that can present on a wide variety of spectrum, a lot of times X-rays or an MRI in some cases are helpful for staging how far along this is, and we have all sorts of different rating and staging systems, and they certainly correlate with how people are feeling and what sort of treatments that they can be candidates for. But the main thing is that you have patients who can function and manage with really bad arthritis, and be able to do activities that they like to do depending on how demanding them and what else they expect of themselves, and in terms of how much they allow symptoms to bother them. So I always tell patients it should be customized to you. It's a stepwise ladder. We start with the very basics, keeping people with their joints supple with a home exercise program or formal physical therapy, such as you guys. We can try anti-inflammatory medications to be used as needed. We can use special types of bracing or canes and things like that if it's needed. And then on the next level spectrum, when the symptoms become flared up or severe, or for maintenance therapy, we do a variety of different kinds of injections, both in my practice and some of my partners do other ones. And surgery is really a last resort for people. There's a spectrum of options, and it depends on where you stand and what your symptoms are.
Yeah, yeah, and I say the same thing. I think it's great advice, and I think for those who have been going through the season of Arthur in their lives, they know they have to keep moving. And even with our patient, right, trying to get them to buy into the concept of look, you. I know you hurt right now, but if you start moving a little bit more, you will feel better. It's hard to really get that message across when people are home, they're not moving, and they're in so much pain. They want to rest. But I think reinforcing, like you said, more and more, and just showing people that they can get through those things, it does help. Now, the spectrum of arthritis is very, very vast, right? We have osteo, we have rheumatoid, we have post-traumatic, psoriatic. Can you just kind of share your experience, what you've seen, what you've worked with, and how the different types of arthritis are different? I think a lot of people get caught up in, oh, I have arthritis, but they might not exactly know what kind they have.
Yeah, so there's different etiologies or sources of arthritis, and then there's different severities, mild to severe, and it's every sort of combination there within. Arthritis just means that your cartilage is degenerated and it started to cause pain. That's all it means. So that can be from a variety of different causes, and it's different for each joint. In the overwhelming majority of cases, particularly for the knee and for the hip, you have what's called osteoarthritis, which is degenerative joint disease. That's primary. Okay, it's not reactive to an underlying inflammatory condition like rheumatoid arthritis, psoriatic arthritis. And primary means that it's caused for just aging, wear, and tear related. It's not due to any particular cause. So, for example, you can have post-traumatic osteoarthritis, which is a result of prior injury, a prior fracture, such as an ACL injury or a prior fracture of the hip or around the knee in the tibial plateau or distal femur. That can cause secondary changes. A small percentage of patients will have inflammatory arthritis from a variety of different kinds. You can have it septic, which means it's an infection. You can have it as a result of rheumatoid arthritis, which is what people commonly think, or psoriatic arthritis. You have an autoimmune inflammatory condition that can cause increased reaction in the joints of the body. In the early stages, that can be managed with very specific types of medications that are anti-rheumatics, and that can help this inflammatory systems that you have systemically. But at some point, you will go on to get degeneration of the cartilage, which cannot grow back, cannot be undone. And at that point, it becomes a mechanical problem that might not respond just to these biologic medication treatments. But the vast majority of people, it's wear and tear arthritis related to age. You do not have an underlying condition. I would venture that number is upwards of 95% for the knee and upwards of 80% for the hip.
Mm-hmm, mm-hmm. Yeah, yeah. And I agree with that. And, Doc, you and I had a chance to meet now because you and I had share a similar patient who has actually been a part of my run club for a number of years. And she's about to have her second knee surgery very, very soon. And I know she gave you my book, so I appreciate you even checking that out. But I have a number of runners, including her, although she's a walker slash fast walker, but some runners who are now in this stage where they are now fearful that what they're doing going to cause arthritis, right? Is running going to cause their arthritis to be worse? Will it cause them to have arthritis at all? There are a lot of different myths and studies and research done on running and its correlation to osteoarthritis in the future, and people have various degrees of knowledge on this. So I'm curious for you, what is your take on running and arthritis? Is it bad? Is it good? Is it helpful? What are your thoughts on this?
Well, so there's a couple different questions to unpack there. So number one, is running by itself bad to get people to arthritis, and is running bad for people who have arthritis? And the answer for each of these is it just depends. Mm-hmm. So in terms of does running by itself cause arthritis, that is a question that has been tried to be answered in multiple longitudinal surveys and series over the years. And the consensus answer is that it's too hard to tell because there's so many confounders that go into it. People who might be running might predispose themselves to actual injuries that can cause arthritis. People who run might be more active in general that predisposes them to arthritis. So by itself, running is not something I restrict people from doing to prevent arthritis. But I do caution that basically your joints have a certain number of cycles with them, right? So you can only put so much mileage on your car, so much mileage on your knees. or so much mileage on your wrists and hands until they become degenerated and you wear out that cartilage sooner. So that's something to always bear in mind. But in general, keeping your joints, bones, and joints supple is important, and keeping yourself healthy by maintaining your weight down, which is something you're likely to be doing when you're running, is also very important. High impact activities can exacerbate arthritis. So if someone already has degenerative changes, it may be harder to participate in high impact activities such as running, jumping, contact sports because it's putting so much force, multiple times body weight through the joint. And the same thing with stairs going up or down can be very difficult, painful
Yeah.
for that. So I always tell people, I never restrict anyone from running. Frankly, after a joint replacement, the manuscript is still in review, but we're close to publishing our series from NYU on looking back at people who do high impact activities such as running after a hip or knee replacement and showing that it does not correlate with failure rates of that joint replacement, at least in the midterm of around 5 to 8 years. So I always caution people that, of course, high impact can theoretically accelerate this. Certainly, if you're having acute pain, it's not something you want to be doing.
Mm.
But the long and short of it is we have very active people who live very long lives, who are running long distances multiple times a week and not degenerating their knees. Of course, as you get older, as the wear and tear piles up, that particular activity may be worse, but it's not something I ever try to restrict for people from doing.
Yeah, that's interesting because I know the narrative for such a long time was once you get a replacement, that's it. No more running. You're done running, right? You're gonna walk, you're gonna work on tall surfaces, you're gonna be on the track. But you're saying that research is now trying to go or trending towards people may be able to get back to doing some kind of walk slash jog slash, some movement that will not just be running. So that's amazing. I mean, it speaks highly to the progress that we've had in terms of surgeries and the ability for people to come back from those things and how great they are now. But also, I think it speaks to the sense that, like you said before, and I've said to my patients also in the past, that movement is something that we need. And
Absolutely.
once you stop moving, everything kind of dwindles down after that. So I'm excited to hear that.
Yeah, so I mean, it's a topic of great interest in mine, Sean, and it's good for us to be able to talk about it because people have a lot of misconceptions of what they're able to do. So historically, when you had a joint replacement, we're talking 80s, 90s, it was contraindicated to run or do any sort of high impact sports
Right.
because there was the theory and some evidence that high impact activity could cause your joint replacement to wear out prematurely. The cement could loosen, the plastic could wear out, etc. We've seen some tremendous progress in the last 20, 30 years, in particular the last 20, where we transitioned away from doing cemented implants for a lot of our joints, certainly for most of our hips, and for more and more of our knees, we're doing cementless implants. So there's not a cyclical load of failure. Your implant grows into your bone, and there's a lower likelihood of that wearing out over time. The other thing is that we've transitioned to using new generations of plastic implants
Mm.
that have much, much lower failure rates and what we call wear rates. So, micro motion at the joint implant surfaces can cause the plastic liner, which is sort of like the tire, if you will, on the car, to wear out over time. That wear rate has dropped down to 1/10 of a millimeter per year in most studies with modern high molecular weight plastics.
Mm.
And the minimum needed to show any significant failure rates is 1 millimeter. So we're 1/10 of where it needs to be.
Mm.
There's data recently from the Mayo Clinic showing that at 20-year follow-up on hip replacement plastics, the chance of a failure is almost 0% from plastic wear, which is huge. So different than what it was 30, 40 years ago with the old generation plastics.
Yeah.
And what that's translated into is more and more people participating in sports, which is an interest of mine. So people have gotten back to doing we have different categories of sports. So low impact, things like walking, swimming, cycling. You're not putting impact through the joint. Intermediate impact sports, things like skiing, doubles tennis. Those things will factor in, and there's a grid. Our Hip and Knee Society has an actual grid of what is each category. And then high impact would be your contact sports, your martial arts, your full strength running. Okay. Historically, the recommendation was that low impact activities are always good. Intermediate impact activities are generally okay as long as someone has experience. And then high impact activities are generally recommended against unless people have good experience with them and it's a patient by patient counseling process. We've looked back at our series here at NYU, and likewise, we've looked at experiences back at my prior institution at Rothman in Philadelphia, and then as well as at HSS here in New York City. And the outcome is that high impact activities do not seem to affect people's return to activities and failure rates in at least the moderate term, so at least the midterm in 5 to 8 years. We don't know if that'll last for the full term, but it's something that we are increasingly passionate about, and I don't really restrict my patients on.
Okay, that's great. Yeah, and I'm happy to hear that because a number of people that come to us pre-op, right? They're coming in and they have the arthritis in their knees and they want to get back to whatever they are doing without pain, but they're so fearful of what's going to happen after surgery. Of course, you don't know what's going to happen until you actually go through surgery, but
Right.
having this hope that they will be able to get back to some kind of activity after that, whether it's going to be the same or even like a version of that. I mean, that makes the whole rehab process easier for people to say, you know what, I can get through this, I can do this, and they can buy into it more. So I'm happy to hear that. I'm happy to
Yeah,
hear that.
the data we looked at for primary first time total hip and total knee replacements is about, you have to factor in some people just don't do these things before they go into surgery, but the people
Right.
who do, the return rates are very high, and about 5% more are going back to doing sports that they weren't able to do previously.
Hmm.
And the ones who are going back to sports that they were able to are doing so with increased satisfaction and increased participation rates, as well as increased intensity and duration of exercise. So, I mean, these are big things, and these are things that people are self-reporting. I mean, they're noticing these differences. These are survey series we've completed at NYU and Rothman, my prior institution.
Yeah.
With more minimally invasive surgery, such as partial knee replacements, those rates are even higher. So
Mm.
we don't want to tell people that, if you are using a cane and only walking to and from the store down the street a couple times a week, that you're going to be able to run and go play basketball. That's not the point. But what is the point is that if you are an active person, you can get back to that, and that includes some contact sports, which is a small percentage, maybe 2-3% of people who have hip and knee replacement, but 2 to 3% are getting back to basketball, soccer, um, flag football, etc. Not
Yeah.
to mention lower impact sports like golf and swimming.
Right, right. So there are a number of different myths that people have talked about when it comes to replacements and the whole to replace or not replace. That's been a question for many, many people who have arthritis. They have a lot of pain. They're kind of on the border of, look, I can get through this. I'm functional, but I have pain every day. I'm trying to get through it. And I always tell my patients, look, as long as you can do what you're trying to do, and your quality of life is good, you're fine. But if you get to a point where you can't do what you want to do, you're having a hard time walking, you're having a hard time getting through your day, then you might want to consider doing this thing and talk to your MD about that. What are your thoughts for those who may have these myths about the efficacy of the replacements, how good they are? People talk about infections kind of happening and settling in. People talk about hardware failing. There's so many thoughts that come into people deciding if they want to do this or not. And the concept of, well, if I just hold on to what I'm doing now, can I get by? What do you tell your patients when they're kind of on that cusp of replacing or not replacing? How do you guide them to make that decision?
Well, so for me, Sean, it's always a very personalized decision and a discussion with the patient. So there are some people who are able to tolerate very radiographically severe arthritis because they have high resilience, good pain tolerance, limited activities, and they're able to do it. There's some people who are very active who can barely tolerate, even mild to moderate arthritis on their hips or knees. And so it depends individually on the patient, but I always leave it up to them. For me, it's a discussion of what the risks are. The risks are never zero, no matter how healthy you are.
Mm.
And there are very few patients who are so sick that you would not consider a joint replacement under any circumstance. It's a careful balance and discussion of your individual risk factors. So things like weight, diabetes, prior infections, heart problems, these things all factor into whether or not how good of a candidate they are for joint replacement. And then after that, it's a discussion of how bad the symptoms are bothering you. I tell patients, you're doing injections a couple times a year and you're generally getting by with your activities, you might be okay. If the injections are only giving you a month or so relief, you're not getting any relief with PT, you can hardly do the things you like to do. And this is my main question: is this the most bothersome thing in your life? Is your knee or your hip the worst thing that's bothering you? Then that's a good impetus to consider doing the surgery. The
Mhm.
satisfaction rates are very, very high. For hip replacement, it hovers around 95 to 98%. For knee replacement, hovers around 80 to 90%. Obviously, a big factor is how severe the arthritis is. Some people, the knee replacement satisfaction rate could be close to 90 to 100% if you choose the right patient. You know what I mean? If you choose someone who really has crippling arthritis, and likewise with the hip. Those are the things I sort of counsel patients on. It's a big decision to go through, but the vast majority of my patients tend to be much, much happier after surgery. And even with high risk factors, it's something we can get you optimized and ready for going into surgery.
Mm. So, I always tell my patients to have the conversation with their MD when it comes to those hard decisions. I know that we see them more than you do after the surgery, right? So we get them to a place where they can be comfortable, be confident to get walking again and get moving again. But the decision to make that choice, right? When we have people coming in for weeks doing their prehab or just coming in for the arthritis, it's a very sensitive time. And I agree with you. I think giving them that question of, what do you want to get back to? What are you trying to do? And like you said, the risks for all people are going to be somewhat there when you're talking about a joint that's wearing down. I'm very, very confident that therapy does help. I'm very confident that movement is medicine. We all know these things, but I do think that's a hard choice for me to decide on. And even for me, Doc, I've had two knee surgeries when I was in high school and in college. I know my cartilage is worn down. I can feel it in my knees, and I don't know if our mutual patient told you, but I've run 9 marathons in my life. So when I tell my people, look, you know what, I'm done running marathons. I got one more to do. I have to do Boston hopefully sometime next year, and that's going to be it. But no one believes me. But
Right.
I believe me because I know what my knee feels like, and I know based on talking to you and others, what that wear and tear over time, especially for that high impact, can really do. Like you said, there's only so many cycles you really have for our bodies. So I'm very, very conscious of that, and I'm very, very careful, even now, in terms of what I choose to do and what not to do. But there has to be some kind of a shift for those who, don't want to do surgery, but do want to do some kind of activity in life, changing their daily routines, finding other things to do. Things like pickleball have come up, and people are trying other ways just to stay active.
Right.
What are your thoughts now on those who do have arthritis, who want to choose options like injections or change their diet or working on their weight? All those different factors as a way to mitigate the knee pain that they may have or hip pain they may have to avoid having surgery. What are your thoughts on people who are in that category?
I'm all for it. I mean, I think anything you can do to avoid an operation is always helpful. And I think that there's a lot of modalities that can get people there. It always starts in a stepwise ladder. We always start with home exercises. If that doesn't work, formal physical therapy with modalities, a long-term relationship with a therapist like you guys. Anti-inflammatories, which can be used to help manage the day-to-day symptoms when they're bad. And then you can do periodic injections. I mean, those are things that are an option, and there's a wide variety out there. In my practice, the tried and true is cortisone, which tends to work very well for relieving acute inflammation for a majority of people. 90% chance you're going to get better for some period of time after a cortisone shot. It may not be a long time, maybe a very long time. It depends on the severity and your particular experience. There's more interest in hyaluronic acid or gel injections, which are a lubricant for the knee. I do offer those as part of my practice. They are covered by most insurances and something we give patients access to. I'm not, I'm not a salesman or jockey for these things. I believe that they're an option for people who want to try. Do they work for everyone? No. That number is probably about 60, 70% who get any sort of benefit from it. Some people do not. You're unlikely to be worse. So as long as it's covered by your insurance, I say try it, see if it works and can delay you needing surgery and help you get to your activities. And there are all sorts of other different biologics, PRP, stem cells, things like that. I don't offer those as part of my practice. I think the evidence on them is fairly mixed. I don't think there's anything wrong with trying. They do come with an out-of-pocket cost, so I always caution patients on that. But so I don't personally offer it, but I think that it's something that can be helpful for people to relieve their symptoms.
Doc, can you talk a little bit more about, you mentioned diabetes and weight as a factor when it comes to arthritis, pre and post replacement. Can you talk about the importance of those factors either helping or hurting someone who may have knee replacement and or arthritis?
Yeah, so diabetes generally is a big risk factor for any surgery, and the how much of a risk factor just correlates to how poorly controlled or well controlled your diabetes is, right? So vast majority of people have diabetes, which is a serious condition, but can be well managed with appropriate medications, lifestyle modifications, and diet and exercise. With those sort of things, people's risk tends to not be super high elevated, and we can do their surgery with very little changes compared to most others. For patients with more advanced diabetes, we have hard cutoffs. So we have what are called A1C cutoffs. An A1C is a measure of your diabetes control. And so I take that into account when deciding whether to offer someone surgery. And there's been good evidence that certain A1C levels should be fairly tight cutoffs for whether to offer people surgery because it can tremendously increase your risk. But the vast majority of my patients who have diabetes are able to proceed with well controlled. Diabetes matters mostly around the immediate surgical period, right? Getting your wound to heal, not getting an infection or having any other type of complication. Weight factors in more globally. So obviously we have good evidence that certain weights above each weight class, BMI of 25, 30, 35, 40, etc., the risk shoots up tremendously of having complications such as infections or mechanical failures. We can mitigate some of those risks, particularly mechanical failures, with some optimization that we can do, but it does factor into the long term. I mean, it might affect your activity level after surgery. It might affect the failure rate or the rate that goes on to fail, whether from an infection or not. And so I think weight loss is an important factor. Certainly very difficult to do when you have arthritic knees to go out and exercise and lose weight. Okay.
Mhm.
Arthritic hips, same thing. We work with people. I have patients who come into the office who do not have well-controlled diabetes or well-controlled weights. We get them optimized. We refer them to nutrition. We refer them to their endocrinologist to get their diabetes under control. We refer them to bariatric surgery. I have multiple patients who are very, very overweight, obesity with BMIs well into the 40s or even 50s, who are not candidates for surgery. It cannot happen, unacceptably high risk. They go and see a bariatric surgeon. They lose a ton of weight. They come back and see me 6 months to a year later. And I've had patients who do this. Doc, I barely recognize them.
Yeah.
And at that point, we can go ahead and fix that joint replacement with, some elevated but acceptable risk. And I think that that's been a big thing for us. These bariatric surgeries and some of these new medications like GLP-1 agonists, your Mounjaros, your Wegovy's, your what's the big one I'm blanking on the name of? I can't remember the one everyone uses.
Uh,
Anyway,
you don't remember
Ozempic.
that.
Oh,
Ozempic.
Ozempic.
Yeah,
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 Ozempic. So, these medications have had tremendous impact on people being able to lose weight, both getting their diabetes under control, getting their BMIs down. And I think that's a big factor. So, we're able to work with people and surprisingly get a high percentage of people down to a place where it's acceptable risk.
yeah. And I know there are a number of people who, even I've seen, and they've come for therapy, but because of their diabetes, because of their obesity, or the BMI, they have a hard time, and they want to get better. Some of them have taken Ozempic and Mounjaro. Some are anti because of all the complications that can come with that on the back end, and it's been it's probably a show by itself talking about the benefits and risk factors of Mounjaro and Ozempic in general. But those who need it, right, have taken it and seen results. And I think it's beautiful that people can get to a place of getting back to, again, the life they love after surgery. My last question for you, Doc, and this is really for both sides, right? We have a number of people who are working on pain management to get through the OA that they have, and they're doing motions of activity throughout the day. They're staying active. They're watching their weight. They're watching their diabetic levels. They're trying to be better so their body can be better. They're taking, all the vitamins from vitamin D to turmeric and whatever else, glucosamine, whatever it takes just to feel better. They're taking everything. Whether it works or not for them, who knows, but they're taking it, right? And then you have people who have surgery. They have the replacement for the knee or the hip. They're doing their therapy. And maybe a couple years go by and the pain kicks in again, right? What do you tell your patients, or what are your thoughts on those in both camps? Those who, have the pain, they don't want to do the surgery because they're somewhat functional and they can get through whatever they want to get through, but the pain is just sometimes just so jarring for them. And those who have had surgery, who've done all they had to do, they did all the exercises, they're being active. And for whatever reason, down the line, because these places don't last forever, the pain may kick in. I had a 92-year-old woman who had both knee replaced, and she's 92, and she came to me for therapy, and I was like, Ma, you lived in a great life. Like, after you've done both knees, the best thing for us to do is just to keep moving. But I'm just curious, in your case, what do you tell these patients who have done what they had to do, but they still have pain? Where do you send them? How do you counsel them? What are your thoughts?
Yeah, so pain after joint replacement's a complex topic. As we mentioned, satisfaction rates are very high for hip and knee replacement, higher for hips than for knees, but still very high. First of all, you got to see a surgeon, be evaluated to see if there's something mechanically wrong, something that needs to be fixed or addressed or taken care of. For some cases, that is the case, but a lot of times, I always counsel patients. I tell them this before surgery. I'm replacing your joint. I'm taking the bone-on-bone part away, but all the soft tissues around your hip, your flexor tendons, your glutes, your hamstrings, around your IT band, around your knee. Again, the IT band distally there. your capsule, your patellar tendon, your quads. These things can all factor in and can still become inflamed and painful in the same way that your knee can hurt when you were a young kid, even though you had a perfectly good joint. So I think being active and moving is a big part. Very often I have patients who come back with a painful knee. We do an evaluation, we do a workup, don't identify much. I get them into physical therapy to work on quads strengthening, getting their extensor chain better aligned and more supple, working out that patellar tendonitis, and the vast majority of people tend to do well. They can add a topical anti-inflammatory and manage those symptoms. The joint itself is functioning, but the soft tissues around it can still be symptomatic. And that's like just like you said, I think being active and moving is important and being plugged in with a good therapist who can help manage this. It's not just about the immediate recovery period. There's going to be the potential for intermittent symptoms here and there, regardless. So that's really how I cancel it. I think it's a lifelong relationship with your joint replacement and your symptoms, and a lifelong relationship with someone who can help take care of you in terms of a good physical therapist and a good rehab team.
Awesome. Dr. Armin Arshi, any final thoughts you want to share with the listeners, the runners who are out there who are trying to keep their arthritis at bay or keep King Arthur at bay, or those who are thinking about having replacement or have had it and they're in a place where they feel like they're pretty good, they're not moving as much as they need to, but probably need to keep moving? Any thoughts you want to share with anyone in those camps?
Well, two things. First of all, I'll say that this is a common problem. You are not alone. There are obviously many listeners to this show and others talking about this topic. I host the orthopedic show on our Doctor Radio Sirius XM channel for NYU, and can't imagine the number of callers we get with these exact questions and issues. This is the standard. I mean, human beings, when you live a long life past a certain age, this is the standard. What you can expect, that your joints will eventually wear off and you may have symptoms, but still have the fire in you to be active. And I encourage that. I think it's important, and you're not alone. The second thing I'll say is we have ways to manage this. Just because you see a surgeon like myself doesn't mean I'm going to recommend surgery. There's a wide spectrum of options, and the vast majority of patients do not need surgery when we first meet them. There are things that we can try to manage your symptoms and make you better temporarily in terms of a quick fix with an injection, or longer term maintenance therapy of keeping your joints supple, like with physical therapy, home exercises, and stretching. So I think that there's a solution out there for everyone in this, but you are not alone. This is very common. The rate of of radiographic arthritis in adults 75 and above for knees is 90%. 90% of people above 75 will have some signs of arthritis, which means that they will have those symptoms intermittently in their lives. This is a normal part of aging until we solve that problem. This is the gold standard, but we have solutions for it.
Yeah. Doc, I appreciate you. How can people get in contact with you or reach you if they have more questions or wanted to see you as their own MD?
Yeah, you can always go to NYU Langone, our website, and find any of our orthopedists. Again, my name is Armin Arshi. I'm a hip and knee replacement specialist. I'm based out of Brooklyn and Manhattan, and see patients throughout. And please be in touch with us. Come see us. You can also find me on our website at arminarshimd.com. So.
Awesome. Dr. Arshi, I appreciate you so much. Thank you so much for making the time today. And I appreciate you. Thank you so much for taking care of our patients, because they are our patients together.
Thank you for taking care of ours, Sean. And I think what you guys do is tremendously important for the rehab process and recovery after knee and hip replacement. We appreciate it and your dedication to patients throughout this process.
Yeah, no problem at all. And folks, don't forget a quote from today. The message is keep moving. If you do, you'll keep arthritis at bay, by Donna Mills. Keep moving, folks. No matter what's going on, keep moving, keep striving, keep pushing. And we will see you next week as we all continue to thrive more in 2025. Thanks for tuning in, folks. Peace.